let us discuss another class of drugs called anticoagulants. So what are anticoagulants? What are the category of drugs which are included under anticoagulants, and what are the uses, contraindications and adverse effects of these anticoagulants will be discussed in this lecture. So, what are anticoagulants? Anticoagulants are the class of drugs which have the capacity to block or reduce the coagulation. That is, coagulation capacity can be reduced by these class of drugs. Coagulation is a process of clotting of blood in the presence of clotting factors. So this coagulation, when coagulation is done, then there occurs or there will be formation of clot in the body. So this coagulation can be reduced by this anticoagulant drugs. What are these drugs? Actually, these drugs don't dissolve any clot. These drugs are not used to dissolve any clot. They are only used to prevent the coagulation. That is what tend to prevent new clots from forming and existing clots from enlarging. They reduce or they won't prevent the existing clots to get enlarged, or they won't allow or prevent the new clots to be formed. But the existing clots cannot be dissolved by these anticoagulant drugs. Let us see the classification of these anticoagulant drugs. There are two categories of drugs. One is in vivo drugs and the other one is in vitro drugs. So the in vivo drugs include parenteral anticoagulants as well as oral anticoagulants. There are various categories in parenteral anticoagulants. First category of drugs are heparins. So in these, heparin is a drug which is used as an anticoagulant, and there are various types of heparins. The first one is high molecular weight heparins, that includes unfractionated or unfractionated heparin. And second one is low molecular weight heparins. Low molecular weight heparins include enoxaparin, dalteparin, tinzaparin, reviparin and danaparin. These are the drugs which are used or which have low molecular weight of heparin. And there are the other category of drugs called heparinoids. Heparin and heparinoids are used as parenteral anticoagulants. Heparinoids include heparan sulfate, hirudin, lepirudin, bivalirudin and argatroban. These are the drugs which are used as heparinoids. Now, let us see the classification of oral anticoagulants. Parenterals are given through IV route. Oral anticoagulants include coumarin derivatives. The first category of oral anticoagulants are coumarin derivatives, which include bis hydroxycoumarin, which is also called as dicumarol, warfarin sodium, acinocomerol, which is also called as nicomelon, and ethyl biscomacetate. And indane derivatives. These are another class of anticoagulant drugs. The drugs which include in indane derivatives are phenandione. Let's see the classification of in vitro drugs. The parenteral as well as oral anticoagulants come under the category of in vivo drugs. Let's see the in vitro drugs. In vitro drugs include heparin, sodium citrate, sodium oxalate as well as sodium edetate. Let us see the blood clotting factors. So this coagulation includes various clotting factors. There are various clotting factors which are involved in the process of coagulation. And these clotting factors include factor 1. Factor 1 of blood coagulation is fibrinogen. Factor 2, prothrombin. Factor 3, tissue factor or thromboplastin. Factor 4, calcium. Factor 5, proaxillerin or labile factor. Factor 6, it is not an independent factor, which is also called as accelerating factor. Factor 7 is proconvertin or stable factor. Factor 8 is antihemophilic factor or globulin A. Factor 9 is antihemophilic B or Christmas factor. Factor 10 is Stewart-Prover factor. Factor 11 is plasma prothrombin factor. Plasma 12 is Hedgeman factor, and factor 13 is fibrin stabilizing factor. So these are the various 13 blood clotting factors which are involved in the process of coagulation. Let us discuss about heparin. Heparin is the class of parenteral anticoagulants. And what are the general properties of heparin? How the heparin is Let us see. So heparin is discovered by a person called Maclean, and Howell and Holt. These are the two persons who gave the molecule or the compound called the heparin as the name in 1918. And this heparin usually occurs in the mast cells. Mast cells are the cells which prone or which tend to release histamine, bradykinin and other allergic compounds. So this heparin is usually occurring in the mast cell in vivo condition, and mast cells are usually found, or mast cells are richly available in lungs, liver and intestinal mucosa. Commercial heparin. The heparin which is prepared synthetically, and it is synthesized from porcine intestinal mucosa and bovine lungs. Porcine and bovine, these are a category of pigs, and from this porcine intestinal mucosa and bovine lungs, heparin is usually synthesized. And heparin is a mixture of straight chain glycosaminoglycans. So glycosaminoglycans are the compounds and they are anionic in nature, and the heparin is a mixture of straight chain of this glycans, and they range in different molecular weights. Based on the number of units of these glycans, the molecular weight of heparin is determined. And heparin is strongly acidic in nature, and it is strongly acidic because of the presence of sulfate group as well as carboxylic acid group in its structure. Let us see the mechanism of action of heparin. How heparin is acted in the body, by which mechanism it is acted. So, if heparin is given in low doses, it shows one action, and if heparin is given in high doses, it shows another action. So, if heparin is given in low doses, it shows two types of mechanisms. One is it inactivates the factor 10A. So all these factors are present as 1A, 2A, 3A, 1B, 2B, 3B, etc. So this heparin, when given in low doses, it inactivates the factor 10A, and it also inhibits the conversion of prothrombin to thrombin, because when conversion of prothrombin to thrombin takes place, it results in the coagulation of the blood. So when this conversion is inhibited, then definitely it shows the process of, or it shows the result of anticoagulation. And at high doses, when heparin is given in high doses, it shows two effects. The first effect is it inactivates the factors like 9, 10, 11 and 12 as well as thrombinol. So all these are inactivated when heparin is given in high doses, and it also inhibits the conversion of fibrinogen into fibrin. This is also the same. When fibrinogen, inactive fibrinogen is converted to active fibrin, then definitely anticoagulant is shown as a result. There are two pathways of coagulation. One is intrinsic pathway and the other one is extrinsic pathway. In extrinsic pathway, inactive prothrombin is converted to active thrombin, and in intrinsic pathway, inactive fibrinogen is converted to fibrin, and all the clotting factors will be involved in both the pathways. But the pathway in which the activation takes place is different, or the coagulation process will take place is different. See, these are the diagrammatic representation of intrinsic as well as extrinsic pathway. So when drug binds, or heparin, which actually heparin binds to prothrombin, and it gives a product called antithrombin 3. So when this antithrombin 3 is formed, it forms antithrombin 3 complex with heparin. So when heparin binds with antithrombin 3, it forms a complex, and this complex inactivates all the clotting factors like 10A, 2A, 9, 10, 11, 12 and thrombin factors, which involves or which inhibits the process of coagulation. As we said, low molecular weight heparins are present and high molecular weight heparins are present. So let us see the comparison between these two. So where does these molecular weight heparins differ? So first thing is, the name itself indicates molecular weight. They differ in the molecular weight. So high molecular weight heparins have a molecular weight of 30,000 daltons, and low molecular weight heparin have a weight of 5,000 daltons. And biotransformation, the biotransformation, how they get transformed into other state in the body is shown. So biotransformation is very low in high molecular weight heparins, and it is up to 90% biotransformation takes place in low molecular weight heparins. And half-life of high molecular weight heparins is shorter and it is dose dependent. Based on the dose given, the short life or half-life is dependable. And in low molecular weight heparin, the half-life is longer. Half-life is nothing but the amount of drug which is eliminated from the body in half time. So that is what half-life mean. And mechanism of action. How does these molecular weight heparins differ in mechanism of action? So high molecular weight heparins differ in the activation of factors 2A and 10A, but low molecular weight heparin only activates 10A factor. And anticoagulant effect. So when compared to low molecular weight heparins, high molecular weight heparins are more effective as anticoagulants. Next, monitoring. How they have to be monitored? They have to be monitored by a PTT, that is prothrombin time, activated prothrombin time. They have monitored by based on this parameter, that is prothrombin time should be regulated or monitored while taking care in giving heparins. And adverse drug reactions. What are the adverse drug reactions seen in high molecular weight heparins? So high molecular weight heparins, we can see thrombocytopenia, that is reduction in the platelet count, and long-term osteoporosis. And when compared to high molecular weight heparins, low molecular weight heparins have less adverse effects of thrombocytopenia and osteoporosis. And excretion. This cleared by reticuloendothelial system, but here low molecular weight heparins are unchanged by kidneys because they can't be eliminated from the kidneys and they remain unchanged. And reversal by protamine. The effect of these high molecular weight heparins can be reversed by protamine, and here they are not fully reversed by protamine, that is low molecular weight heparins. And expensive. High molecular weight heparins are not expensive when compared to low molecular weight heparins. These are few of the comparisons between high and low molecular weight heparins. Let us see the advantages of low molecular weight heparins over high molecular weight heparins. Why low molecular weight heparins are advantageous than high molecular weight heparins? First thing is they have better SC availability, that is subcutaneous availability. Usually heparins are given through IV route or subcutaneous route or oral route. So subcutaneous route and IV route are better choice than oral route. So low molecular weight heparins have 70 to 90% bioavailability. The amount of drug which is available in the systemic circulation is called as bioavailability. So low molecular weights when given in subcutaneous route, they are available in 70 to 90%, but high molecular weight heparins when given in subcutaneous route, the bioavailability is only 20 to 30%. And the other advantage is better and consistent half-life. So when compared to high molecular weight heparins, low molecular weight heparins have better half-life. The drug can be in the systemic circulation for longer period of time so that it can show better action. And since a PPT or clotting time are not prolonged, low molecular weight heparins require fewer lab monitorings, because we saw like this monitoring is based on the prothrombin time. So low molecular weight heparins need not be monitored for every few hours, or monitoring is not required in frequency. So that is the reason these are more advantages when compared to high molecular weight heparin. And lower incidence of hemorrhagic complications. In overdoses, they cause hemorrhagic conditions. There will be over loss of blood. So low molecular weight heparins can cause reduced hemorrhagic conditions when compared to high molecular weight heparins. So these are the fewer advantages of low molecular weight heparins over high molecular weight heparins. Pharmacokinetics. How these drugs ADM, that is absorption, distribution and metabolism and excretion of this heparin takes place. Heparin is highly charged, poorly crosses cell membranes and thus given parenterally. When it is given orally, it has to get absorbed into the cell through the membrane. So when it is given IV or intravenous, it directly enters into the systemic circulation and can show the effect, because it is anionic in nature and it is highly charged because of the number of units present in the heparin. And for low dose, in low doses of heparin is given through subcutaneous route. High doses of heparin is given through subcutaneous route as well as IV, that is intravenous. And metabolism of heparin is usually taken place in the liver. The heparin, when enters into the liver, it gets metabolized and the end product is released into the systemic circulation. And half-life depends on the dose given. The half-life of the heparins will depend on the dose given. When the dose is given in higher amount, half-life is longer, and when they are given in lower dose, half-life is shorter. Let us see the pharmacological actions. When heparin is given, what are the actions we can observe in the patient? First one is anticoagulant activity. So heparin prevents coagulation. So it acts as an anticoagulant drug. Powerful and instantaneous acting anticoagulant, and it is effective both in vivo as well as in vitro, because heparin is given in vivo condition as well as in vitro condition also. And sudden stoppage of this dose therapy causes rebound increase in the coagulability for few days. If we stop the heparin suddenly, the drug therapy of heparin is stopped suddenly, then there will be increased risk of coagulation. And it also has antiplatelet activity. Antiplatelet activity in the sense it prevents the action of platelets in the process of coagulation. So when heparin is given in high doses, it has two effects. One is it inhibits platelet aggregation, and the other one is prolongs bleeding time. When platelets are nothing but thrombocytes which are used in the aggregation of the blood. So when platelet aggregation is inhibited, then definitely it shows antiplatelet effect, and it prolongs bleeding time. The bleeding time of a person, the bleeding time differs from person to person. So this bleeding time can be prolonged when heparin is given in high doses. In lipemia cleaning, that is in the cleaning of lipid which is present in the body. If there is any blood clot, if there is any atherosclerotic plaque, it is somewhat dissolved or it is cleaned up by heparin. How the procedure is done, let us see now. So heparin, when given in low dose, it releases lipoprotein lipase. Lipoprotein lipase is an enzyme which is present in the vessel walls and tissues. The blood vessel walls and tissues have lipoprotein lipase enzyme. So when this lipoprotein lipase enzyme is released, it hydrolyzes the triglycerides of chylomicrons and VLDL to free fatty acids. So VLDL, very low density lipoproteins, and chylomicrons and triglycerides are hydrolyzed in the presence of lipoprotein lipase into free fatty acids. And then free fatty acids can be cleared easily through heparin when it is present in the lipidemic state in the plasma. Let us see the adverse drug reactions of these heparin. Heparin causes adverse drug reactions like when given in overdoses, it causes bleeding, it causes allergy, anaphylaxis, alopecia, long-term osteoporosis, and thrombocytopenia. These are few of the conditions which are caused due to adverse drug which are caused due to overdose of heparin. Anaphylaxis is an allergic condition, severe allergic condition. Thrombocytopenia is a condition where there is decreased platelet count. And drug interactions. When should this heparin be contraindicated? So, or what are the drug interactions when heparin is given? Heparin when combined with corticotropin. Corticotropin is a drug when combined with heparin. It shows increased toxicity of corticotropin and there will be severe hypotension. This is a drug which is used in the hypotension, and when it is combined with heparin, it shows synergistic effect. And heparin should not be combined with mifepristone. Mifepristone is a drug which when combined with heparin, it shows excessive post-abortion bleeding. So after abortion, the bleeding will be over when heparin is combined with this drug. And heparin when combined with aspirin, it shows anticoagulation, or there will be increased anticoagulation effect, and that is dangerous interaction, because when heparin is combined with aspirin, when anticoagulation activity of heparin is increased, there will be hemorrhage, overloss of blood. And heparin when combined with fluorouracil. Fluorouracil, when combined with heparin, it shows increased bleeding effects. That is nothing but hemorrhage. And when heparin was combined with mipomersin, this causes increased hepatic enzyme levels. When hepatic enzyme levels are increased, then it causes toxicity of the liver and other organs also. Heparin in pregnancy. How heparin and pregnancy are related? So when drug in pregnancy is given, it cannot cross the placenta very easily. So instead of heparin, if warfarin is used, warfarin is a drug, anticoagulant drug, which crosses the blood placenta easily, and it causes changes in the fetus to cause fetal warfarin syndrome. So warfarin should not be used or in combination with heparin, or heparin should not be used alone, or warfarin should not be used alone, because heparin, however, it does not cross the placenta, and warfarin, if crosses the placenta, it causes warfarin fetal syndrome. Contraindications. When should this heparin be contraindicated, or in which condition? First one is hypersensitivity. In hypersensitivity condition, in bleeding disorders, for example, hemophilia, thrombocytopenia, intracranial hemorrhage, GI ulcerations, gastrointestinal ulcerations, threatened abortions, and advanced renal or hepatic diseases. If a patient is suffering with any of these disorders, then heparin should be strictly contraindicated, because it shows synergistic effect, or it occurs more loss of blood or hemorrhage. Right. Let us see the uses of heparin. How or when heparin is used. Heparin is usually given in the treatment and prevention of deep vein thrombosis. If a person is suffering from deep vein thrombosis, heparin is given to reduce the thrombotic effect. In IHD. IHD is a rare condition which is characterized by glaucoma and underdeveloped iris. So IHD is a rare medical condition where glaucoma and underdeveloped iris can be observed. So in IHD, how heparin is used? For unstable angina and post-MI, post-myocardial infarction. Next, after angioplasty and CABG, that is coronary artery bypass grafting, and stent replacement for prophylaxis. So in these conditions, heparin can be used. And in rheumatoid heart diseases, rheumatic heart diseases, or atrial fibrillation, to dissolve the fibrin clots, heparin is used. Thereby it decreases the stroke. And in cerebrovascular disorders, to dissolve cerebral embolus. Cerebral clot or cerebral embolus can be dissolved by heparin. In vascular surgery, this heparin is used. And in defibrillation syndrome, in defibrillation syndrome, mainly it is used as a to prevent thrombosis, and it is used as a ADR, that is antibody formation against thrombin. So heparin is used in defibrillation syndrome as a to prevent thrombosis. Heparin is used. Next, let us see the heparin antagonist. The heparin antagonist is protamine sulfate. Protamine sulfate is used as an heparin antagonist. It is strongly basic in nature. Because heparin is highly acidic, the antagonist should be strongly basic in nature, and it is low molecular weight protein, which is usually obtained from sperms of certain fish. From the sperms of certain fishes, this protamine sulfate is usually prepared, and it is given only through intravenous route, and it neutralizes heparin weight for weight. That is, 1 mg is needed for every 100 units of heparin. So for 100 units of heparin, for every 100 units of heparin, 1 mg of protamine sulfate is given to neutralize the effect of heparin. And in the absence of heparin, protamine itself acts as a weak anticoagulant by interacting with platelets and fibrinogen. If heparin is not present in the body, and if heparin antagonist is given, it itself acts as a weak anticoagulant. It is not a potent anticoagulant, but it shows less anticoagulation effect by interacting with platelets and fibrinogen. Let us see the heparinoids. We have discussed about heparins. Now let us see the heparinoids, the other class of parenteral anticoagulants. So these are the drugs that bind to thrombin without additional binding proteins such as antithrombins, where heparin is acted through a mechanism of antithrombin. Heparin binds with antithrombin 3 to form heparin antithrombin 3 complex, but heparinoids act without any without any forming complex with antithrombin. They directly act in the blood clotting factors, so in the process of coagulation. Let us see what are the examples of the drugs which are used as heparinoids. One is hirudin and bivalirudin. These are the two drugs which act as which are catalytic in nature, and they act at the site of thrombin, and they also bind at substrate recognition site. So when any substrate which binds to the receptor, when substrate it binds to the receptor, it shows coagulation, it involves or initiates the coagulation procedure. But here the hirudin or bivalirudin, they bind to the substrate site and they involve or they inhibits the coagulation procedure. Next, argatroban. This is another heparinoid drug which only binds at the thrombin active site, because it binds only at the thrombin site. That is, thrombin is mainly used in the coagulation process in the intrinsic pathway. So that is the reason when thrombin active site is replaced or when thrombin active site is occupied by this drug, then definitely coagulation process will not occur. The other drug is lepirudin. Lepirudin is a drug which is monitored by PTT, that is prothrombin time, and it is action independent of antithrombin. As usual, these drugs usually act without antithrombin binding itself. And bivalirudin acts by inhibiting platelet aggregation. The platelets which are present or thrombocytes which initiates the coagulation, usually this platelet aggregation procedure will be inhibited by bivalirudin, and it is used in precutaneous coronary angiography. And let us see the other class of drugs, oral anticoagulants. Till now, whatever we discussed are parenteral anticoagulants, and let us discuss about oral anticoagulants. Oral anticoagulants include warfarin. So let us discuss about warfarin in detail. Warfarin is a synthetic derivative of coumarin, and it is usually prescribed to the people with increased tendency of thrombosis, who are prone to more thrombosis. Then usually warfarin is preferred, or to those individuals who already have formed clots. If a person is having clots in his body, this warfarin is used because it dissolves the existing clots, and it is contraindicated in pregnancy to prevent excessive bleeding. And let us see the mechanism of action of this warfarin, how warfarin is acted. So which is vitamin K dependent synthesis. It inhibits vitamin K dependent synthesis, which is a biologically active form of calcium dependent clotting factors. So when the vitamin K dependent synthesis is blocked or inhibited, then calcium dependent clotting factor release will be inhibited. For example, let us see the mechanism in pictorial representation. Descarboxyprothrombin or factors 7, 9, 10 are descarboxyprothrombin is in the inactive state. So when this inactive state is converted to prothrombin, that is active state, then vitamin K hydroquinone and vitamin K epoxide, they initiate the release of the clotting factor. So this vitamin K hydroquinone to vitamin K epoxide conversion is inhibited by these oral anticoagulants. And that is the mechanism by which they act. By inhibiting the vitamin K, then definitely the release of coagulation factors will be inhibited and there occurs no coagulation. Let us see the pharmacokinetics of warfarin. So warfarin is 100% bioavailable. If warfarin is given through IV, then 100% of the drug is bioavailable and it's rapidly and completely absorbed after oral administration. After giving orally also, it is 100% bioavailable, as well as it gets rapidly absorbed into the tissues or cells. And high plasma protein binding capacity. So when warfarin it gets inside the body, or when it is taken orally, it gets bind to the proteins which are present in the bloodstream, and there it exerts its action, and it crosses placenta very easily. In pregnant women, if warfarin is given, it crosses placenta very easily, and it shows hepatic clearance. Hepatic clearance will be observed if warfarin is given. And metabolism. There are various metabolism process which takes place in the liver for a drug to get metabolized. So few of the process include oxidation, reduction, glucuronidation, etc. So this warfarin, when taken orally, it is metabolized in the liver by a process of oxidation and glucuronidation, and it is usually taken for every 12 to 16 hours before effect is observed. What are the adverse drug reactions of these warfarin? Warfarin causes excessive bleeding. When warfarin is given in overdose, it causes excessive bleeding in gastrointestinal area and internal hemorrhages. In the organs, there may be internal hemorrhage observed if warfarin is given in excess dose. The other one is cutaneous necrosis. If a skin gets damaged, or if a skin gets injury, then there occurs bleeding. If warfarin is given, it causes cutaneous necrosis. The overbleeding of any organ, or the overbleeding when the overbleeding occurs at any site, then whatever the area which is there, it gets necrosis occurs at the site. Because of the overbleeding, there occurs necrosis at the cutaneous site. So when warfarin is given, it shows adverse drug reaction of this cutaneous necrosis due to overbleeding or activation of the protein C. And infarction of breast, fatty tissues, intestinal and extremities. So decreased activity of protein C, it shows the effect of venous thrombosis, and thereby it causes all these symptoms. When warfarin is given in these conditions, then the protein C activation is decreased, which causes thrombosis of the veins. Hypoactivity of warfarin causes. If warfarin is given in low doses, what are the causes it can show? It is usually affected in pregnancy due to increase in the clotting factors. So when low doses of warfarin is given in pregnancy, there will be decrease in the release of the clotting factors. There may be the proper clotting may not take place. The clotting where necessary may not take place if it is given in low doses, and nephrotic syndrome can be observed, and warfarin resistance can be seen if it is given in low doses. Hyperactivity of warfarin. When warfarin is given in high doses, what is the activity can be observed? We can see malnutrition, we can see effects of newborns, and we can see liver diseases, and we can observe chronic alcoholism and hyperthyroidism. Hyperthyroidism usually occurs because of increased degradation of clotting factors when warfarin is given in more amount. Warfarin toxicity. To prevent the toxicity of warfarin, what can we give? To stop warfarin, administer vitamin K, because warfarin acts through the mechanism of inhibition of vitamin K. So when vitamin K is given, the action of warfarin can be stopped, or vitamin K is also called as antidote of warfarin. Or apart from vitamin K, the other substrates can also be administered, like fresh frozen plasma, the plasma which is freshly frozen, and prothrombin complex concentrates, and recombinant factor 7A can be administered as the antidote of warfarin apart from vitamin K. What are the contraindications of warfarin, or when should be the warfarin contraindicated? It is usually contraindicated in pregnancy because it shows fetal protein in bone and blood will be affected. And birth defects. If a baby is born, then definitely there will be defects in his birth, and abnormal bone formation, bone hyperplasia, CNS defects, fetal hemorrhage, fetal hypoprothrombinemia, and fetal death can be observed in pregnancy conditions if warfarin is given. So it should be strictly contraindicated in that condition. And other contraindications are usually the same of that heparin. What are the drug interactions? Where can be the drug interactions observed with warfarin? So pharmacokinetic interactions are drugs that inhibit warfarin metabolism. There are few drugs which inhibit the metabolism of warfarin. If warfarin is not metabolized, then definitely the warfarin action will be inhibited. So pharmacokinetic interactions include the drugs like cimetidine, imipramine, cotrimazole, chloramphenicol, chlorprofloxacin, and amiodarone and metronidazole. These are the drugs which inhibit warfarin metabolism. So the warfarin should not be given when these drugs are given to the patient for other medication. Drugs that increase warfarin metabolism. Over metabolism of warfarin is also shows inactivation of warfarin. So barbiturates and rifampin. These are the drugs which causes increased warfarin metabolism. So warfarin should be strictly contraindicated with these drugs. And drugs that displace warfarin from binding sites on the plasma albumin. So it displaces or they get bind to the site at which warfarin have to bind. Warfarin have to bind at the plasma albumin site to show its action. But the drugs like chloral hydrate and NSAIDs, they replace and they get bind to the plasma site, plasma albumin site, and thereby inhibiting the effect of warfarin. So drugs that decrease GI absorption of warfarin, that is cholestyramine. Cholestyramine is a drug which decreases the GI absorption, that is gastrointestinal absorption. As warfarin is given orally, it should be absorbed into the gastrointestinal tract. So this absorption is decreased by cholestyramine drug. So warfarin should be contraindicated in this condition. Let us see the pharmacodynamic interactions. So it shows synergistic effect with heparin and aspirin. So heparin and aspirin should not be combined with warfarin because it shows synergistic effect, as heparin and warfarin both are anticoagulant drugs. So there may be adverse effects or synergistic effects when combined. And warfarin should not be combined with antibiotics also. So when combined with antibiotics, it decreases bacterial flora and thereby it decreases vitamin K synthesis. And when vitamin K synthesis is decreased, then definitely warfarin effects are increased. So that is the reason warfarin should not be combined with antibiotics. Now, let us see the uses of warfarin. So usually the uses of warfarin are same as that of heparin. It is used in IHD and various other conditions. It is used in surgery, CABG, and this warfarin should be monitored in frequency. The administration of dose of warfarin should be monitored. This monitoring is necessary because if it increases or if it reaches therapeutic index, or if therapeutic index is high, then definitely there occurs adverse reactions. So, and prothrombin time is the main measuring factor to monitor the dose of warfarin as well as heparin also. Usually patients on heparin are shifted to oral warfarin only after 3 to 5 days. So if a person is taking heparin IV, then the person can take warfarin only after 3 to 5 days because this is given orally and that is given IV. And if heparin and warfarin combine, it shows synergistic effect. That is the reason after giving heparin, the 3 to 5 days time should be there for the heparin to be completely eliminated from the body so that warfarin can be used. Let us see the comparison between warfarin and heparin. So the route of administration of heparin is parenteral and the route of administration of warfarin is oral. And polarity. Polar charged molecule and warfarin is uncharged. So as we discussed earlier, heparin is anionic in nature. So it is polar charged and warfarin is uncharged. It don't have any cationic or anionic charging on it. And onset of action. Heparin shows immediate action because it is given IV. As it is available in the systemic circulation instantly, it shows rapid effect. But for the warfarin, the onset of action is 12 to 16 hours. To exert its actions once taken inside, it will take minimum 12 to 16 hours. And mechanism of action, how these drugs are acted. Heparin is acted through inactivating the clotting factors by forming complex with antithrombin 3. But warfarin, it does not combine with antithrombin 3, but it inhibits gamma carboxylation of glutamic acid residues of clotting factors. So what happens is like the clotting factors have glutamic acid, and when this glutamic acid is getting carboxylated by the process of gamma carboxylation, then the clotting factors release will be inhibited. And therapeutic index. So therapeutic index of heparin is not low. That is why it is safer for use. But warfarin therapeutic index is very low. That is the reason it's not safe to use. And monitoring. Both are monitored via prothrombin time. And adverse drug reactions. Adverse drug reactions of heparin include alopecia, osteoporosis and thrombocytopenia, whereas warfarin includes cutaneous necrosis, breast and other fatty acid tissues infarction. And management of patient. How the patients have to be monitored in case of heparin and warfarin. So heparin, the person can directly start with heparin, but warfarin, how warfarin can be used is that first the patient has to be treated with heparin, then only he can get shifted to warfarin treatment after 3 to 5 days. And antidote of heparin is protamine sulfate, whereas antidote of warfarin is vitamin K. And contraindication is pregnancy. So heparin cannot be contraindicated in pregnancy, however, because it cannot cross placental barrier. But here warfarin crosses placental barrier and it is very dangerous to the fetus. That is why it is contraindicated in pregnancy. And drug interactions. There are no much significant drug interactions in heparin, but warfarin drug interactions are very significant because we have both pharmacodynamic as well as pharmacodynamic drug interactions in warfarin. This is about anticoagulant drugs.